And I found that I have some tools that can help even in that situation, and particularly among kids and working with parents who were more strident in their anti-vaccination.
Hello, I'm Faith Rogers, host of today's program, COVID-19 Keeping Up with a Moving Target. This is the December 18th episode of DKB Med Radio's Coronavirus Educational Series. Thank you for joining us. As a note to our regular listeners, this will be our final week of episodes in the year 2020. We will resume our regularly scheduled episodes on Wednesday, January 6th of 2021. We encourage you to take this opportunity to listen to previously uncompleted episodes or view our other free CE/CME programs on a wide variety of topics at dkbmed.com. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC and AAPA credit, as well as AMA PRA Category 1 credits. Please visit our website for complete CE information. If you're tuning into our webcast, please click the red Claim Credit button in the webinar console to attest for credit. Otherwise, please visit covid19.dkbmed.com. There you will also find all of our previous COVID-19 programs and have access to other free CE programs on a wide range of topics. Today's learning objectives are: describe strategies to counter vaccine hesitancy, and discuss currently available safety data pertaining to the messenger RNA vaccine that recently received emergency use authorization. With us today, we have Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine. He will be interviewing Dr. Chuck Vega from UC Irvine School of Medicine. Dr. Auwaerter, Dr. Vega, thank you for your times.
Yeah, well, thank you, Faith, and I'm delighted that Dr. Charles Vega has joined us to help share many of his thoughts, especially from a primary care perspective regarding vaccines. And I think in this segment of the program, or at least I thought it would be reasonable to talk about people that have vaccine hesitancy. Now, this isn't necessarily anti-vaxxers, people that really have deeply held beliefs that I think generally that they want either natural infections or they really don't want to intervene by artificial bases. But first, stepping back, California's been a bit at the forefront in many respects regarding immunizations after the measles outbreak in Disneyland, and there's now a state bill that I think for the most part requires children to have full sets of immunizations before entering public school in California. What's been your experience just talking to your colleagues and also patients with that particular, I mean, it's not mandatory because you have other options, but it is very, it's very prescriptive.
It is, and we need it. All the credit in the world for that law goes to Dr. Richard Pan, who was a practicing pediatrician, who was the residency program director in pediatrics at UC Davis before joining the state senate here in California. It took a lot of courage. He had death threats. He had to have a security detail. His family was threatened. Yet, I think through passage of that law, it just reinforces how important vaccines are, particularly for young children, with these potentially terrible illnesses when we know we have highly effective and safe treatments such as measles. Gosh, it's so disappointing to have to think about measles again, but it's something we do have to deal with on a routine, not a common illness, but something we see routinely in a big state like California. They're trying to actually add more to the law in terms of avoiding non-medical or even some medical reasons that might be questionable in terms of folks who don't want the vaccine, and so we need support on the policy level. There's no doubt, and I'm a big believer in that law and that movement, and I do try to be a little bit prescriptive. So I will, for example, with influenza vaccine, it's part of the plan, and it's just I'm not really asking patients, do you want an influenza vaccine? It's, well, today, thanks very much for coming in again. We're going to check an A1C level. I'm going to refill your metformin. we're going to increase your amlodipine by 5 milligrams, and then we're going to give you a flu vaccine before you leave. Does that sound okay?
Yeah.
And
Well,
and that more presumptive model can work, and it's something that I find we know that it's effective for kids. It can be effective for adults as well. But I'm of course willing to have a conversation with somebody with vaccine hesitancy. That's something I do routinely in my practice.
yeah. So, and I think those kind of strong recommendations about a vaccine, or that it just seems so part of the routine that these are protective, they're safe. It's just the normal course of action. It's nothing fancy, it's nothing abnormal. It's just part of routine medical care is very important. But I think we have to make clear that although you have the state law in California, at least for the new coronavirus vaccines, all of which will likely be improved first by the Food and Drug Administration only with emergency use authorization, which means they're investigational. People have to sign consents and be informed of the risks and benefits of the vaccine. However, there's no mandatory requirements yet. You haven't heard anything about that necessarily. Just to be clear, no one, at least here in Maryland, there's no intent to make coronavirus vaccines mandatory.
Yeah, we have a pretty aggressive approach, obviously, as a state, but I haven't heard of any of those types
Right.
of concerns or programs that are being espoused for the COVID-19 vaccine specifically.
Right. There's no doubt going to be a lot of questions about the new coronavirus vaccines. The first two are relatively similar, but there are many more that are coming in different formulations. They work a little differently. So there's going to be a big knowledge base that I think even, myself as a specialist have trouble keeping up with, but can imagine this is coming fast and furious when you have so many other responsibilities to take care of in your office. But the group that's probably toughest to convince are going to be people that don't take vaccines at all, for example. And maybe that's not a very big segment of the population. It does vary a little bit, but it's only usually, it's usually under 10% that have sort of strident views. But for those that are just vaccine hesitant, that's probably a larger group. And that's a group that just generally has concerns and so on. And uh, what's been your experience, perhaps from other vaccines, in terms of trying to address their hesitancy about vaccines, especially when there's uncertainty here with a brand new vaccine and some brand new technologies?
So thank you. I certainly have some feelings on vaccine hesitancy is something I deal with routinely. I don't see as much vaccine resistance. Of course, those folks kind of self-select. They're not coming in for a lot
Right.
of wellness visits, right? But I do have some experience, and I've found that I have some tools that can help even in that situation, and particularly among kids and working with parents who were more strident in their anti-vaccination thinking. And so I can address that as well. But so for most folks with vaccine hesitancy, it's I certainly let them tell their story. I listen with empathy. I want them to go on and use an iterative explanation as to why they don't want the vaccine, because a lot of times there isn't a solid core when patients start to peel back. Well, I'm worried about the safety. Okay, tell me what you're worried about the safety of it. Tell me about that worry. Well, I'm just afraid it'll cause some serious side effects, such as what? And using that iterative process, people generally just kind of run out of steam, and eventually they say, yeah, I guess maybe I should get the vaccine. I couple that when they run out of steam moment, that's when I say, well, actually, I understand the concerns that you have, and of course we want to be safe. Your safety is our top priority, right? First, do no harm. And but the fact is that these vaccines have been used in X number of individuals, and we know about their safety profile. And I'll be honest about data. If there is probably some risk of an injection site reaction, of course I'm going to warn patients about that. But larger issues such as autism or promotion of cancer, there's just no data there to support it. And I'll state that. But I quickly try to pivot from that because I don't want to get an argument. And then go right into, okay, but I know it's safe, for one reason is because I received it, and my mother received it, and my
Right.
wife and my kids have received it,
Yeah.
and we are on time with our vaccines, and that makes us healthier in the long run. We know that these vaccines applied broadly can really reduce the burden of disease, and it's going to be important for you and for the people you care about. For protecting them as well, because maybe it's not you feel invincible, but you live with an 88-year-old woman with heart failure, history of stroke, and Parkinson's disease. You may have a newborn at home. So I think that working with the patient and their particular priorities, trying to get some of those things out there through that story, being empathic about it, and then turning the recommendation personal, not citing CDC, not citing the advisory group on immunization practices, but focusing more on that personal approach is very worthwhile. And then quickly on the anti-vaxxers, I do same process, listening with empathy. I know I'm not going to get a complete win. We're not going to convince you to take everything, but I have found that I can usually get some vaccines on board. It's not the most scientific approach because really the patient's choosing based on what they've heard and where their information is, but something is better than nothing. And so I'm not, I don't need to get the complete win here. I'm happy with with just getting a first down and staying in the game, and developing a relationship through that interchange where I show respect and empathy. Where maybe next year we may have a different attitude. So it's sometimes I've got continuity. That's my secret weapon in primary care. We may not get there on that first visit or even the second, but maybe the fourth or the fifth visit. Keep trying and keep that equanimity. And I think that's an important role because I have seen attitudes change over time as trust builds.
Sure. Patients eventually stop smoking. You just have to keep trying. I think you have some excellent thoughts there to try to help and occasionally break through. I think you're right. Personalizing things is so helpful. I have found, people are not very interested in TDAPs, but if you start saying, "Oh, you have a new infant grandchild,"
Right.
suddenly, that's a no-brainer. You don't want them to get pertussis as an infant, and they sign right up, even if their arm swelled up a bit from the last one 10 years ago or so. Uh, you know, these vaccines, of course, won't be given to children initially, really adolescents. We'll see where the FDA draws a line. Not too many even adolescents got immunized. So probably is going to be mostly an adult vaccine for starters. So, thinking about your adults in your primary care practice, what do you feel are going to be the questions that you're going to have to prepare your staff for too? Because I think, it's not only you, but the people in the office that if they don't have some of these answers, I have a feeling, especially we don't know if we're going to be administering them in all of our offices, but if we are, they're going to ask for some insights as well, often from office staff.
Yeah, I think that's a great point, and you really want to be speaking as one. So whatever handouts or educational materials should reflect what you're actually telling patients. I find personally that the mode of communication, directly face to face, even on even if it's via an interface like on the computer with telehealth, is better than written materials. But everybody should be on board and having the same approach. And really, it comes down to two questions: efficacy and safety. I think the efficacy is there. Safety, I think it's worth stating what we don't know. Like, we don't know the long-term safety. It's impossible to know long-term safety with these vaccines. But there's going to be so many millions of people vaccinated around the world and there's going to be so much scrutiny of those individuals and how they're doing, both in terms of, do we see the curve of the pandemic bent backwards, but are we doing so safely as well? And are there post-marketing reports for smaller safety signals, but important ones? So that is something that's going to be tracked, and nobody in the who we're seeing as patients is, unless they're a healthcare professional of some type, somebody who's on the front lines, is going to be in that first band. So we'll take the first, we'll be the first ones to to go through it. We have that personal experience, so we can talk to that. That will be critically important. And then be honest about the things we don't know. But I I am very certain that that we will be able to find those potential safety signals if it's a problem. I think there's also a concern, not so much among my patients, but I've had a couple people focus on this type of vaccine being RNA vaccines, the first RNA vaccines that are they're bound to be used on a broad basis, about the safety of that technology in particular, and is this going to hijack my RNA and my own genetic processes of my body and do all kinds of weird things. I think that's a vague concern I've heard from multiple people as well, who probably kind of have enough insight to realize that this tech is different and special. I don't know if you have a special way of addressing that.
Yeah, I do a little bit. What I try to say is, at least for the mRNA, it's no different than a virus, except the virus is inserting 6 or 10 genes, for example, and this is only one. So there's nothing very new or novel, and also the RNA degrades pretty quickly. It doesn't really persist. It's not integrated into chromosomal structures. I think what we don't know a lot about are just the lipid formulation ecostructures that surround it. What I tell patients, Chuck, are that from most major vaccine trials, major safety signals, stroke, heart attack, things that, put people in the hospital, you find out in the first 4 to 8 weeks, in the vaccine. So we already don't see that. We don't see early deaths or anything. Of course, as you said, we have to tell them the knowns, and we know the local reactions, and they may be sick transiently. So we have to be upfront on that. The unknowns are just tougher. I mean, we don't have the long-term safety data. That's why the vaccine's not fully approved. It's going to be waiting until later in 2021 when we have all the safety data. And there's always looking for vaccine or autoimmune diseases and so on. But so far, these trials are going on in real time and looking for those kind of problems. And I'd say blessedly, they really have not come about so far. So, overall, I just say it's reassuring, but there are unknowns, and a lot of people don't like uncertainty.
No, of course not. And of course, we wish we had perfect data too, but especially this past year, if nothing else has taught us, we have to move forward because it's a crisis. And so we can't necessarily wait for the perfect. The good will have to suffice for now. And that's why ongoing study is so important. And I can also point to the fact that when there was a safety signal, look at the AstraZeneca Oxford vaccine trial was halted for a substantial amount of time because of a potential safety signal, which was judged to be not related to the vaccine. But I think that just shows that the scientists behind this are taking safety as seriously as you do as a patient. They're probably thinking about their own families and themselves, and so of course they want to create a safe product. And I think that was a good example of not. I think people will look at it as a negative, like, gosh, they're hiding something because the study was stopped for several weeks. Well, actually, I think that putting the brakes on was just a sign that just shows how careful they were, and eventually they found there were no major safety signals associated with that vaccine.
Well, this certainly is not the end of the story. We're going to have lots more information, more vaccine candidates, and other impacts on the dynamics of this pandemic. But certainly these are the first rays of hope, I think, as we enter the winter time. So Chuck, I really want to thank you for sharing your expertise, your insights, also how to handle vaccine questions, which are going to be coming fast and furious at us all over the next few weeks. So thanks so much for staying with the program.
If you're tuning into our webcast, please click the red Claim Credit button in the webinar console to attest for credit. Otherwise, please visit covid19.dkbmed.com. Any questions or issues, feel free to email us at the address listed. To submit questions, please send them to qa@dkbmed.com. That's Q as in question, A as in answer, at dkbmed.com. Again, thanks for joining us, and thank you for your dedication to your patients with COVID-19.